International Journal of Health Policy and Management. Quality and speed are our culture and the keys to our success. Welcome to the audio summary section of the International Journal of Health Policy and Management.
Hello, I'm Professor David Chinitz from the School of Public Health at the Hebrew University-Hadassah in Jerusalem, Israel. 2 years ago, I was on sabbatical in Paris, and so was my good friend and colleague, Professor Victor Rodwin from the Wagner School of Public Service at New York University. And being two professors with time to reflect, and over many cups of wine and espresso, we came to the conclusion that we share a certain malaise about our field of health policy and management, and we don't feel that the field has had an impact in the reality of health delivery systems commensurate with its teaching, writing, and research. And so we began to wonder why this was. And we started by noticing that in the context of the Affordable Care Act, or Obamacare in the United States, many solutions seem to be recycled under new names. Health maintenance organizations became accountable care organizations. Health technology assessment became cost-effectiveness analysis. And value for money became value for patients. But this recycling of old ideas indicated to us that something is not right. And so we identified 4 factors that we think lead to our malaise. The first is the dominance of economics in the field of health policy and management. Economists have made substantial contributions to the conceptualization of problems and formulation of solutions in many areas of social policy. But that contribution can only take us so far. And in healthcare in particular, the difficulty in defining the outcomes of delivery systems and policies make it important that we not try to rely only on market models or economic methods such as cost-benefit analysis to try to determine our decisions, because things like the benefits of healthcare are very difficult to quantify. They involve a lot of values and a lot of criteria that are hard to aggregate. But there's an attraction to economics as a parsimonious Occam's razor way of providing solutions because it has such forthright and clear recommendations. The problem is that those recommendations do not always conform to the real world of healthcare systems. And this led us to our second obstacle, which was to look at competing or complementing disciplines such as health management. And we found that our complaint about the limits of using economic analysis is not really answered by trying to supplement with management theory, because management theory seems to, in a way, fall into the same trap of trying to provide clear and, as it were, normative solutions to how to manage and regulate health systems, but it ignores one of its own central principles, which is the contingency approach, which says that any organizational or management tool, in order to work, has to be appropriate to the contingencies and special conditions of specific health contexts. And that led us to our third obstacle, which was that we feel there's a lack of comparative case studies of health care policy and management from which we could, over time, accumulate wisdom and knowledge about the workings of such systems and do better in trying to recommend context-relevant ways of intervening to try to continually improve such systems. And we realized that using case studies as an approach is difficult in academia. Single case studies are hard to generalize from, and we don't really have a well-worked out method for combining the knowledge and wisdom from an aggregate of case studies. And also the policy environment is very impatient and is looking for quicker solutions than can be provided by this kind of ongoing accumulation of knowledge that would be provided by this type of approach. And our fourth obstacle is that we feel that there's a big disconnect between what is coming down from theory and policy to the frontline delivery of healthcare. And we feel that physicians in particular are socialized for a long period of time to treat individual patients and give them top-rate medical care, but they are not attuned or oriented to the learning by doing situation that they will be in when they enter the health system. And I think that we need to tailor our policy and management interventions in order to better enable physicians and other health workers to learn by doing on the job and adapt to the changing dynamics of health systems. The article in which we summarized these points in the International Journal of Health Policy and Management generated some very interesting and sometimes critical responses. Victor and I enjoyed that, as we will enjoy any comments on this short summary of that article. And with that, thank you for listening, and we'd like to wish our best to the readers and video viewers of the International Journal of Health Policy and Management.